effect medications have to reach their target cells and bind to a receptor. Receptors are specialized proteins found inside the cell or on its surface. When receptors are bound by a signal molecule, called a ligand, they can alter their shape or alter their activity, which ultimately results in some change in the cell's activity or behavior. Starting with cell surface receptors, these are embedded into the plasma membrane, and based on their structure and properties, cell surface receptors fall into three main types: ligand-gated ion channels, G-protein-coupled receptors, or GPCRs, and enzyme-coupled receptors. First are ligand-gated ion channels, which form channels or pores that are generally closed, but then open up once they bind a specific ligand. This allows ions like chloride, calcium, sodium, and potassium to flow into the cell and trigger the signaling pathway. Next are the G-protein-coupled receptors, also known as 7-pass transmembrane receptors, which means they are really long proteins that have one end that sits outside the cell, and then the snake-like protein dips in and out of the cell membrane 7 times and finally ends on the inside of the cell. The ligand binds to the end sitting outside the cell, and the end of the protein that's within the cell activates guanine nucleotide-binding proteins, or G-proteins, which go on to stimulate or inhibit different sets of enzymes and molecular pathways within the cell. Finally, enzyme-coupled receptors are usually single-pass transmembrane proteins. The extracellular end of these receptors binds to ligands, and their intracellular end has enzyme activity. When a ligand binds, the intracellular end gets triggered, activating other proteins in the signal pathway. In contrast, intracellular receptors are typically located in the cytoplasm or nucleus of the cell. Once bound to their ligand, the receptor-ligand complex attaches to specific DNA sequences that activate or inhibit specific genes. Now, depending on the effect a medication has on its receptor, they are often divided into two major categories: agonists and antagonists. An agonist is a medication that mimics the action of the signal ligand by binding to and activating a receptor. Agonists can be divided into full agonists, which can produce a maximal response, and partial agonists, which can only produce a submaximal or weaker response. In other words, a full agonist is like a really well-made spare key that's just as effective as the ligand, while a partial agonist is a poorly made spare key that could open the lock, but it takes longer. An example of a full agonist is morphine, which binds to the mu-opioid receptors, as well as the delta and kappa-opioid receptors, to produce an analgesic effect. In contrast, pentazocine is a partial agonist to the mu-opioid receptors, so it produces a less powerful analgesic effect. On the other end of the spectrum, an antagonist is a medication that typically binds to a receptor without activating them, but instead blocks the receptor so that it can't be bound to and activated by agonist ligands. An example is naloxone, which is an opioid antagonist that binds to opioid receptors, blocking their effects. Now, the way a medication and receptor interact with each other is ruled by two main principles: affinity and intrinsic activity. Affinity is how strongly a medication binds to its receptor. This is mainly determined by the strength of the chemical bond between the two. The higher the affinity, the higher the potency, which determines the amount of medication needed to elicit an effect. So, medications with high affinity can produce an effect at a lower dose. Okay, after the medication binds to its receptor, it must also be able to have an effect on that receptor. This is known as intrinsic activity. Ultimately, the intensity of response to the medication depends on both the number of receptors bound to the medication, as well as its intrinsic activity. The maximal effect the medication can produce is called the efficacy. Alright, Now let's plot all this into a nice graph to show the relationship between the amount of a medication given, also known as dose, on the x-axis, usually on a logarithmic scale, with the response produced on the y-axis. What we get is an S-shaped curve, called dose-response curve. At first, the curve is more or less flat. That's because the dose is too low, so not enough receptors bind to the medication to cause a significant response. As the dose increases, more receptor medication complexes form, so the response to the medication climbs upward. This is described as a graded dose-response relationship. Eventually, we reach a point where all the receptors get occupied, so the curve starts to flatten out. Now, the point where all the receptors are occupied is where the maximum response or effect, abbreviated as Emax, is achieved, which is a measure of the medication's efficacy. Now, if we move to the point where 50% of the maximum effect is produced, the effective dose of the medication producing this effect, known as ED50, marks its potency. So, the smaller the ED50, the less it takes to get halfway of the maximum effect, so the more potent that medication is. Okay, but if the dose gets too high, it can result in toxic effects or even death of the client. So the TD50 is defined as the average dose that causes a toxic response in 50% of the population. In animal studies, LD50 is defined as the average lethal dose or the dose of a medication that causes death in 50% of tested animals. Now, if the ED50 gets divided by its TD50 or its LD50, we get the therapeutic index, or TI for short, of a medication. The closer to 1 this ratio is, the narrower the therapeutic index, which means there's a greater danger of toxicity, so doses should be tightly regulated. Medications with a wide therapeutic index are safer, since their toxic dose is much higher than their effective dose. On the flip side, medications with a narrow therapeutic index are more dangerous, since they have close toxic and effective doses. Two examples of medications with a narrow therapeutic index are lithium, which is a mood stabilizer, and theophylline, which is a bronchodilator. Let's go ahead and create a new graph, this time with medicine concentration on the y-axis and time on the x-axis. Now, the minimum concentration of a medication needed to achieve a therapeutic effect is known as the minimum effective concentration, or MEC for short. On the flip side, the minimum concentration of a medication that has a toxic effect is defined as the minimum toxic concentration, or MTC for short. The range between the minimum effective concentration and the minimum toxic concentration of a medication is equal to its therapeutic window, and describes the range of a medication's dose or blood concentration that can treat a disease effectively without having toxic effects. Once a medication is administered, it requires some time to reach its minimum effective concentration and start producing a response in the body. This is known as the onset. If a rapid onset is needed, a loading dose, meaning a large initial dose of the medication, is given first. On the other hand, the time required for a medication to reach its maximum effectiveness is known as the peak. Finally, the length of time that the medication's concentration is enough to result in a therapeutic response is known as the duration. Okay. Before administering medication to your client, keep in mind some of the general pharmacodynamic principles that relate to the medication. Start by performing an assessment of your client in order to establish a baseline for monitoring and to identify factors that may affect pharmacodynamics. Review their medical history for certain genetic mutations, malnutrition, and diseases like cardiovascular disease, myasthenia gravis, and Parkinson's disease. During your assessment, consider client characteristics that may affect the pharmacodynamics of their medication. During pregnancy, the response to medications may be altered by changes in hormone levels as well as the increased cardiac output by 32 weeks of gestation. Likewise, in pediatric clients, the varied receptor site sensitivity, immature organ function, and rapidly developing tissues can also affect pharmacodynamics. On the other hand, in older clients, pharmacodynamics can be affected by changes in medication sensitivity, affinity of receptors to medications, as well as decreased organ efficiency. Lastly, keep in mind how your client's weight may impact pharmacodynamics. Be sure to always have an accurate weight for your client before administering weight-based medication doses to achieve a therapeutic effect, whereas clients who weigh less than average may need a smaller dose to avoid toxicity. Next, review information about the pharmacodynamics of the prescribed medication. Additionally, review the medication's onset, peak, and duration of action, and use this information to guide administration of the medication, as well as monitoring for both side effects and therapeutic effects. For example, if a client with diabetes is prescribed a rapid-acting insulin like insulin aspart, avoid hypoglycemia by making sure the client's breakfast tray is already in the room before administration, which ensures your client can eat within 5 to 15 minutes of administration. You'll also want to be aware of medications such as aminoglycosides, digoxin, warfarin, and lithium, and monitor your client carefully when administering these medications. For example, you will often check the trough level of gentamicin to avoid neurotoxic and nephrotoxic effects, as well as to ensure the medication level is adequate to treat your client's infection. Likewise, for clients taking warfarin, the INR should be routinely measured, and you should teach your clients to self-monitor for signs of bleeding. Also, keep in mind how medications interact with receptors throughout the body and how these interactions can manifest as side effects in addition to the desired therapeutic effect. So, if you're administering the antihistamine diphenhydramine to a client with pruritus, you should look for the therapeutic effect of decreased itching as the medication competes with H1 receptors in the periphery. In addition, be sure to also monitor for side effects like sedation due to blocking of H1 receptors in the central nervous system. Likewise, when administering morphine for pain, you should look for the therapeutic effect of reduced pain, which is mostly due from morphine's activation of mu receptors, but remember to also monitor for side effects like sedation, and take measures to decrease the risk of constipation due to morphine's activation of kappa receptors. Finally, after your client has started their medication, continue to assess for factors that influence pharmacodynamics, and use this information to monitor for side effects and evaluate the therapeutic effect. Alright, as a quick recap, pharmacodynamics refers to the effects of a medication in the body and how they do it. Most medications bind to a receptor on their target cells in order to exert their effects, and the three main types of receptors include ligand-gated ion channels, G-protein-coupled receptors, and enzyme-coupled receptors. A medication can be categorized as an agonist or antagonist based on its effects on the receptor. Affinity describes how strongly a medication binds to its receptor, and impacts its potency, which refers to the dose needed to elicit an effect. The effect a medication has on its receptor is known as intrinsic activity, while the maximal effect a medication can produce is referred to as efficacy. A dose-response curve illustrates how more receptors being bound to the medication creates a greater response, but eventually all the receptors are occupied and the maximum effect is achieved. A dose too high can cause toxicity, and the therapeutic index of a medication represents the margin of safety, with a narrower therapeutic index indicating a greater risk of toxicity. The therapeutic window is the range between the minimum effective and minimum toxic concentrations and describes the range of a medication used to elicit a therapeutic effect while avoiding toxicity. The onset, peak, and duration of action describe the time-related elements of a medication's effectiveness. Nursing considerations related to pharmacodynamics include assessing the client for factors that impact the effects of their medication, reviewing the pharmacodynamic properties of the medication, and monitoring the client's response to it. Client teaching focuses on the desired therapeutic effect of the medication, safe self-administration,